We are live.
So good evening, postgraduates, teachers, and all the mentors today. Welcome to this 77th episode of All India Postgraduate Teaching Program, which is an initiative from Academic and Research Committee of All India Ophthalmological Society. Today is our 77th episode. We started in the month of July last year, and today is the 16th Journal Club. Today's Journal Club would be presented by Dr. Akanksha Sinha, second year RIO student from RIO IJIMS Patna. And the second journal would be presented by Dr. Nisha Pillai, who is a junior resident at RIO Minto Eye Hospital, Medical College and Research Institute, Bangalore. I'm indeed thankful to the mentors, Dr. Anita Ambasta, who is an additional professor at RIO IJMS Patna, and Dr. Chinmay, who is a professor at RIO Minto Eye Hospital, Bangalore, for guiding their students. Of course, my special thanks also goes to the discussant, Dr. Shweta Chaurasia, Dr. Anita Gangar, and Dr. Vaishali Rakeja. Dr. Shweta Chaurasia is an associate professor from Advanced Eye Center, PGIM, Chandigarh. Dr. Anita Gangar is a consultant ophthalmologist and associate professor at GRIP MER Sri Sir Gangaram Hospital, New Delhi. And Dr. Vaishali Rakeja is an assistant professor at Department of Ophthalmology, BR Ambedkar State Institute of Medical Sciences, Mohali, for consenting to be discussant. Now, without much ado, can I request our member ARC West, Dr. Anaga, to carry forward the proceedings?
Yeah, thank you so much, Dr. Prashant, and a very warm welcome to one and all. So we are going to have a very good discussion on this journal club today. I would like to request Dr. Akanksha to be the first presenter and to present a case.
Good evening, all. I'm Dr. Akanksha Sinha, and I'm going to present an journal for ARC Journal Club under mentorship of Dr. Anita Ambasta. So the journal which I've chose is titled as Acute Optic Neuropathy in Older Adults, Differentiating Between Myelin Oligodendrocyte Glycoprotein Antibody-Associated Disease, Optic Neuritis, and Non-Arthritic Anterior Ischemic Optic Neuropathy. So this article was published in Journal Neuroimmunology and Neuroinflammation with a impact factor of 8.3, and it was published in May 2024 by Tezavipat and et al. This study was conducted to differentiate two most common acute optic neuropathy causes, that is optic neuritis, in which this study is focused on MOGAD, a demyelinating disease, and another one is non-arthritic anterior ischemic optic neuropathy. So these two share overlapping features that possesses a diagnostic challenge for any clinician, and differentiating these two entities leads us to early treatment in MOGAD group, which usually responds well to treatment. So the aim of the study was to identify key differentiating characteristic between these two diseases and to determine the frequency of serum MOG IgG false positivity among patients with NAION. It was a multi-centric case control study which was conducted over 5 neurotertiary centers in Israel, Thailand, and United States up to February 2023. And the frequency of serum MOG IgG testing and false positive results were done in Mayo Clinic, Rochester, each year from 2018 till 2022. It was approved by Mayo Clinic Institutional Review Board and pertinent institutional review boards in the participating centers. So first of all, the MOGAD cases are defined as the patients that fulfill the 2023 updated MOGAD criteria. So I would like to take you to the diagnostic criteria. So a core clinical demyelinating event should be present in a patient along with a positive MOG IgG test that is clear positive. That is the titer should be 1:1000. If the patient has low positive without reported titers, or negative but CSF protein with oligoclonal bands are present, then aquaporine 4 IgG seronegative a patient should be, and along with a supporting clinical MRI features that are indicated as below. And along with that, exclusion of other criteria, other diagnosis, including MS, should be priorly done. So this study excluded patients with prior MOGAD attacks, accompanying neurological symptoms, and bilateral optic neuritis cases. So basically, this study included MOGAD cases that were unilateral with their first attack, and age of patients were 45 years or older. For NAION cases, the two aims that were seen in the two aims that were in the study. For the first aim, that is to identify the key differentiating features, the patients of NAION should be age matched and sex matched with clinical diagnosis of NAION. Clinical diagnosis includes acute vision loss with optic disc swelling with age of 45 years or older in patients within 5 years of MOGAD optic neuritis onset age. Other causes of optic disc swelling and incipient NAION were excluded. For the second aim of testing a MOG IgG false positivity, NAION patients from Mayo Clinic were taken from 2018 to 22 with no optic nerve enhancement on acute or vital MRIs. So they analyzed patients over multiple parameters. The first one were demographics, in which age of onset was taken along with gender, race, and the distribution of patients over centers. Comorbidities included diabetes, hypertension, obesity, dyslipidemia, obstructive sleep apnea, cardiovascular disease, smoking, and along with that PDEF5 inhibitor use. Moving to clinical manifestations, the patients were assessed for maximum vision loss beyond 48 hours, vision loss at NADI, any preceding headaches, headache side, eye pain, and its severity. Optic disc, perimetry, and OCT findings were done within 14 days of onset of vision loss. So the optic disc was defined as crowded disc when the ratio of less than 0.3 was noted in the affected eye or unaffected eye. On the altitudinal visual field defect were reported in patients of NAION, and in this, either the perimetry was used or the patient complaint were also taken into account. Moving to OCT, Cirrus HD OCT has been done, in which the artifacts were excluded and peripapillary RNFL thickness were measured with 200 into 200 Cirrus protocol covering 6 into 6 millimeter square area, center and optic disc. Along with that, a macular cube scan of 512 into 128 Cirrus protocol was done to assess the GCIP segment measurements. An important term that is used in this is estimated peripapillary RNFL thickening, which was identified as difference between the affected and unaffected eye. And accordingly, the grading of optic disc edema was done according to mild, moderate, and severe. Moving to treatment part, they have analyzed all the patients for the treatment they received over the duration, and seen in both the cases group. So moving to management outcome, patients were analyzed over 3 months and over 1 year for the vision loss, and along with them the relapses that were seen in each groups, and on the basis of that, the event in the either in the same eye or the contralateral eye. So the data was analyzed, and multivariate binary logistic regression was done in this study. P-value less than 0.05 was statistically significant, and the software was used that is as shown below. So moving to results, 64 patients of unilateral MOGAD optic neuritis were compared with 64 patients of NAION. So the mean age of onset was seen as 56 years, and 70% of cohort were female. The cohort was predominantly white, as most of the patients were from Mayo Clinic Research Center, and the proportion was relatively less common in MOGAD group. All the comorbidities were equal distribution in both the groups, but two comorbidities, that is dyslipidemia and obstructive sleep apnea, were significantly common in NAION group. Similarly, smoking and PDEF5 inhibitor use were seen most commonly in NAION group. So half of the patient with MOGAD had vision loss that wasn't beyond 48 hours, which was more in comparison to NAION. And preceding headaches, that especially ipsilateral, and eye pain was more commonly a feature of MOGAD. Similarly, severe vision loss at nadir was also more common in MOGAD, but altitudinal visual loss was most commonly seen in NAION group. Moving to disc edema. So disc edema was present in all cases of NAION as it is by definition, but optic disc edema was present 67% cases of a MOGAD group. The disc edema was more severe in NAION group, as the RNFL thickening, peripapillary RNFL thickening was more seen in NAION, more severity in NAION, and no acute changes has been seen in GCIP. This chart shows the same. Now moving to treatment part, of MOGAD group, 81% received high dose steroid and 88% received other treatment trial like plasma exchange or IV immunoglobulins. NAION groups, 8% received high dose steroids and about 10% received low dose steroids. So of total, we can see that no treatment was given in 83% of NAION group in comparison to MOGAD, in which only 10% received no treatment. In outcome, it is seen that on follow-up of 3 months, MOGAD had better visual acuity than NAION, and after 1 year, more number of relapses were seen in MOGAD group, of which most of them were in the same eye. But in NAION group, most of them were in the fellow eye. So after conducting a multivariate analysis, they came to a conclusion that these three predictors were strong predictors for the MOGAD. That is eye pain, absence of crowded optic disc, and absence of altitudinal visual field effect. They conducted the study on a subgroup of patients with optic disc edema, and combining these three features led to improvement in specificity of this disease, that is MOGAD, to over 99.9%, and the positive likelihood ratio also increased to 414. Now the second aim was to test false serum MOG IgG false positivity. So in this 5-year duration, 212 patients of NAION were seen in Mayo Clinic Center, and of these 119 confirmed to have no optic nerve enhancement, but only those patients which had non-classical picture of NAION were tested for MOG IgG, and of these, about 5 patients only had positive serum MOG IgG. Then they were advised for MRI, and it was seen that only one patient had optic enhancement, while the other 4 had no optic nerve enhancement, leading to only 8% of false positive rate. So I would like to analyze this article. First of all, I would like to understand the title itself. So the first line, that is acute optic neuropathy in older adults. This line itself is a broad term, which we can think about multiple reasons of optic neuropathy. But the second line shows the differentiating between both the diseases. But it lacks any precision in study design or any diagnostic focus or any clinical relevance that is important. So it could have been phrased in a much better way, as I have shown in examples like multi-center case control study of acute optic neuropathy in older adults, differentiating MOGAD and NAION. Now, the research question was good. We have analyzed it according to finer criteria. It was feasible as data availability was good in a multi-centric study. Sample size was also good, 64 patients of each group. Resources used were OCT, MOG, IgG, that is very good as it focuses on the latest technology. But expertise were also good as the institution is renowned and the clinicians there are assumed to have conducted the study properly. It is interesting as both the diseases had some overlapping features if we take the group that is 45 years or older, and differing treatments are given according to that. So many studies have been done on NAION and MOGAD, but no head-on-hand comparison has been done between these two. So this makes the study novel. Ethical approval has been taken, and it is relevant as early treatment in MOGAD cases leads to better outcome. Moving to MARI index. So this study has adequate size and sample, but the study design was retrospective, which induces potential biases. The study population was over 5 tertiary neuroophthalmic center, but we can see from this chart that there is a major chunk of sample was from Mayo Clinic, which leads to a particular race, focusing more on Caucasian race. It was moving to assignment. It was approved by institutional review boards. Confounding variables were tried to match through matching of age and sex, which is good to avoid any variability. Multivariate analysis has been done, which provides excellent, strong predictors for MOGAD. Moving to assessment, the study had 2 aims, which make the study a little cumbersome, as the second aim, which was testing the MOG IgG false positivity, it has not been much justified because the results have been not interpreted well. Clinical examination was adequate and standardized, but the associated fundus findings like disc hemorrhages could have been taken into account because it provides important differentiating between both of them. Similarly, investigation also, the new latest technology, that is Octa, has not been taken into account. It has been great if we would have been able to compare these both. Moving to MRI findings were also not included in this study, which could have been differentiating factor. Perimetry program and strategy was also not specified. Data collection, retrospective design leads to recall bias and many other potential biases. The diagnostic criteria was well defined in the study for both the groups. but there was lack of uniformity in the distribution of patients from all the centers. And also for the second aim, that is MOG IgG testing, there was a lack of, there was only one center sample was taken, and it could have been better if multiple centers could have been taken into account. Moving into results, this study shows that MOGAD group has a relatively lower proportion of white, but all over the cohort were white, and many studies, as included below, that shows that there is no marked sex or racial predominance seen till now in MOGAD cases. Significant risk factors that were considered statistically significant is shown as below. So in this, the following clinical features are also seen in many other studies. These are supported by other studies, but only one patient of NAION was seen to have eye pain, which was rather insignificant. So we do not take into account, and these are good clinical features that should be analyzed. So all the other segments like acute treatment, good visual recovery, and more chances of relapse, these are good predictors, but they do not, we cannot use them in our patients if they come with acute episode. Moving to NAION group, dyslipidemia and obstructive sleep apnea, although these are they're already supported by many studies, but these are also seen in MOGAD group. So we cannot use them as good predictors. Other features are also justified as they have already been studied till so far. Now coming to the second part, that is false positive serum MOG IgG testing. In this study, 8% patients were seen to be false positive. A similar study was done by the authors in a previous study that shows that 2% false positive rate was present. And a similar study was done by Nguyen et al., which shows a 21.7% false positive rate. So it can be seen that it is has a lot of variability, and it cannot be used as a diagnostic, solely it cannot be used as a diagnostic technique. And so other factors like clinical and radiological features are important. And in all small titers of less than 1:40 cannot be taken as a diagnostic criteria. So in coming to interpretation, these three presence of these three predictors are important in our group if we want to analyze the patient and differentiate them from NAION. So this study could have been more better if multiple centers could have involved, and predominantly it was cohort of white population, so it can't be generalized in our patient group. And the key differentiating which they provide are good, but this which helps us in preventing unnecessary serum MOG IgG testing, as it is not easily affordable by our patients. And some MOGAD patients also saw altitudinal visual field effects, which were not addressed by the study. And along with that, the second aim was also not conclusive, as many studies were done that shows that positive predictive value is good and also helps to predict the future attacks of MOGAD, but this was not analyzed or any addressed in the study at all. That's all. Thank you.
Yeah, excellent presentation. Yeah, let's have some discussion.
Yeah, please. Yeah, you have presented quite nicely. I just have a question here. In this paper, have they mentioned about the positivity of like 6 patients were positive for MOG in NAION
8%.
patients? Yeah, 8%. There were
8%.
6 patients only, 6 patients.
Yeah, 6.
Among, I think, 20 patients which were tested for 56% of the patients who 66% of the patients who were tested for MOG, right?
Yes, ma'am. Yes, ma'am.
So in these 6 patients, have they mentioned about the levels? I mean, how high it was? It was a borderline or it was too high? Have they mentioned?
Yeah, they have mentioned the chart. Yes, ma'am.
And they were like from all the centers, or it was from one center? Is it something about this has been mentioned in the paper?
Yes, ma'am. There's a column in the paper that shows that multiple centers and their positive titers, that they have measured the titers, and most of them we have it was seen that low titers were most commonly seen in all of the patients. So
Low titers.
Yeah, low titers. 1:20 is the 1:20 and 1:40. Between them most of the patients were seen.
Okay.
So 1:100 is the criteria that we consider as per the MOGAD 2023, that at least 1:100 that should be present, titer should be present.
Yes.
Okay, so it's an excellent study, but in Indian scenario, like NMO and MOG are quite expensive tests. So NAIN is a clinical diagnosis, right? It's based on history. You take a history of predisposing factors. Okay, age is of course a factor, and predisposing factors. Then you see the fundus, the crowded disc, and other factors like tilted disc, crowded disc. And then you see for the field test, you go for the field test. If you have an altitudinal defects, the diagnosis becomes quite clear. And then again, the symptoms, if there is a headache or pain or ocular movements, all this rules out NAIN. So I think there is a very, and then you go for an MRI. And if there is no enhancement on an MRI and there is no lesion on MRI, the MOG gets ruled out automatically. So I think in a clinical scenario, I would like to other panelists, how often do you see the confusion between the diagnostic dilemma between MOG? Because in our scenario, we do not find that difficult to diagnose a MOG positive optic neuritis in an old patient versus NAION. So how, Dr. Anita, you would like to throw some light?
Yeah, in fact, the reason why this paper was chosen, because we found it a bit interesting, because usually we have this aquaporin 4 optic neuritis versus MS versus MOG, studies comparing that. And we thought, whether is it really possible that we might be getting confused between these two conditions? And so what this paper says, it's a very, well-written paper. What they say is that there's the overlap age, like the NAION decompression study, that surgical decompression study took patients above 50. So this study is taking above 45. So there might be a cohort of patients who are younger slightly with same comorbidities, considering that we have a lot of hypertension and diabetes happening in younger lot, also smoking in it. So we might be missing a small number of patients who are sort of falling in the overlap category, slightly younger, and in that lot.
I agree with you, but the first question is we go for an MRI. And if an MRI, it's very important to have a 1-to-1 ratio with the radiologist. Okay, the good MRI is there because I see MRI myself. Okay, so I see for T2 hyperintensity, I go for a post contrast T1. I compare the coronal sections post contrast, fat SAT images. If you have an enhancement, because mostly MOG optic neuritis involve the posterior part of the optic nerve, so disc edema might not be there, and NAION also have mild disc edema. So if suppose there is a disc edema, then if you are still confused with this is an optic neuritis, then you have to see for the enhancement. If there is an enhancement in the subtle enhancement also, it is very, very obvious on MRI. So MRI is a very beautiful tool in order to, and if you have some other lesions in brainstem or is myelitis, then the picture of optic neuritis is. Otherwise, in my scenario, I do not get confused between NAION and MOG positive. Yeah, there could be some population which might have a positive, because only if you could see out of 118 patients, only 6 were positive, and that also there were low titers, and there were different centers. There were only 3. There were 3 centers. There were 6 patients. So maybe some patients might have MOG positivity, but
totally agree with you. Because this is what I found. I found it slightly strange that we are having problems in differentiating, because the moment you get altitudinal, that is why we wrote in that thing that only in certain MOG patients where you have altitudinal field defects, you can have a diagnostic dilemma, and that has not been addressed.
Even fields can have, like, if the patient is not very cooperative or vision is too low, you might not get good fields. But MRI is a very beautiful tool if it's done very, very correctly, and if the radiologist or the ophthalmologist is looking at itself, then I think there is no confusion between NAION and...
Yes, and that is another thing which she has written when she has analyzed by the Mari.
It's just that this paper just highlights that few of the patients can have MOG positivity even in NAION. That's a separate thing, because it is an the cause of vision loss is NAIN, and MOG positivity is just a associated finding. Okay, but the cause of the vision loss is NAIN in that case. So I still believe that there should be no confusion in our clinic, because we do not go for NMO MOG straight away because it is an expensive test. We go for an MRI first. So I think that's my opinion.
In fact, one of the reasons why this was taken out because we found fallacies like you have had, and we wanted some discussion, and so we got this article out, and with the high citation and all that. And this is why we wrote that, she has written that MRI was not done, and it should have been done, because we would have had findings, and we could have compared the findings, which was not done there. So it just narrows down to a very small overlap patients. Even in our scenario, we don't get so much of NAION in young patients. So what I thought was that they lost a great opportunity. They had a multi-centric study. They were doing it in Japan, with a lot of dietary differences from the West and from us. Maybe could have had more input regarding demography, regarding the, which people are having more of MOG, because the sample size is not, it's totally, the cohort is mostly Caucasian coming from Mayo, and not adequate representation from the from the Oriental population in Thailand or in Japan. So I think this was a good opportunity for many takeaways from a multi-centric study across continents, which was missed. Plus, I would have also liked to know how many neuropathy, optic neuropathy they are seeing in a particular time, and what were the conditions which was leading to those optic neuropathies, so that I know how much of MOG they are seeing in Thailand, in Japan, and in US, and how much of NAION they are seeing, and that would have been of more interest to us from this point of view. And in fact, this was one of the reasons why we wanted to critically analyze, this article. Because as I told my jury, it's like comparing apples to oranges. I mean, not exactly, a little bit.
Good evening, everyone. Hi, Shweta. Very nice discussion. Already it's happening. Here I would like to add, yes, as already Dr. Anita ma'am said, so there are very less chances of overlap between these two diagnoses. And clinically, most of the time, it's the altitudinal field effect. Even without doing perimetry, we know that there is a altitudinal field effect, which directly tells us that it is NAION. So clinically, there are less chances of overlap, but then in especially the complicated cases, confusing cases, which we are not able to differentiate clinically, Shweta is very rightly said that MRI is the one tool which would be more informative, and while doing that can show the lesions, and yes, so that we can definitely do our first step. So Akanksha, very nice presentation of the study.
You,
yeah.
One thing more I want to add here, that this paper brings a very one thing this paper adds to for our information, that since the diabetes, hypertension, metabolic disorders, they are all increasing. So one should be very careful even in young patient diagnosing NAION. You should look MRI very carefully before you diagnose it at NAION. That's one thing which this paper adds.
Yeah. And I think I would like to see more studies. Along with history of diabetes, they are taking history of what all anti-diabetic drugs they are using. With the recent interest weight loss and oral hypoglycemic agents and its association with NAION, I think that's something interesting that we can look forward to adding here.
Right. So great discussion, excellent inputs. So shall we move on to the next presentation? So I'd like to request Dr. Nisha to please start her presentation.
Yes, ma'am.
Welcome, Dr. Anita. I think you joined in between. Yes.
I'd just like to take your leave, all of you in between. Sorry.
Good evening, everyone. I'm Dr. Nisha Arpillai. I'm a junior resident from Minto Ophthalmic Hospital, and my moderator was Professor Dr. Chinmay ma'am from Rio, BMCRI. So today for the Journal Club, I would like to present my presentation is on comparison of surgical decompression and steroid therapy for the management of traumatic optic neuropathy, a systematic review and meta-analysis.
while the screen starts to share, I'll just highlight why we chose this particular article because, okay, I think, yes, go ahead, Nisha.
So my topic is comparison of surgical decompression and steroid therapy for the management of traumatic optic neuropathy, a systematic review and a meta-analysis. At the outset, I would like to say that in an ideal situation, we would not be doing a systematic review and meta-analysis for a JC, but being the topic being neuro-opthal and the cases being fewer, it's very difficult to get good randomized controlled trials and also cohort studies. And that is why we chose to go for systematic review and meta-analysis, which also has a highest quality of evidence. And as far as we can see in this pyramid, background information and expert opinions come at the base of the pyramid, where there's a large information volume, but a lot of unfiltered information at the same time. And as we ascend the pyramid, we can see that systematic reviews and meta-analysis have got good quality of evidence and also more filtered information. At the same time, traumatic optic neuropathy are the kind of cases that every postgraduate will at a point in time come across in their career, and it is also independent of geographic distribution. Furthermore, this article is actually published in a craniomaxillofacial journal, and it also gives us an idea of the cross-specialty experience with regards to such kind of cases. And it helps us understand their approach, because more often than not, the primary contact of this patient may not always be with the ophthalmologist. Rather, it can also be with the neurosurgeon or the OMFS. So the chief author was Dr. Sameer Pandey, MDS, from AIIMS Rishikesh, and Ghosla S. Reddy. The corresponding author was Dr. Sameer Pandey. This was published in the journal Craniomaxillofacial Trauma and Reconstruction, 2023, volume 6. And this is the citation. This is in Vancouver style. Just for everyone's information, these are the citation formats that are available. The most commonly followed one in our institution is Vancouver style. So as far as the journal is concerned, it was published in SAGE journal with craniomaxillofacial trauma and reconstruction subset. It's a peer-reviewed journal with an impact factor of 0.8 and a 5-year impact factor of 1.3. And just few words on impact factor. So it is actually mainly dependent on the number of times that the article has been published, has been cited in an index journal. It is not associated to factors like the quality of the peer review process or good citations and also the quality of the content of the journal. But rather, it's just a measure of the average number of citations of the article. Some of the highest impact journals that we have are Nature, which has 50.5, Lancet, which is 98.5, and JAMA, which is 63.5. I would also like to mention about Indian Journal of Ophthalmology, which has an impact factor of 2.1. So there are certain guidelines which are available for reporting studies. This ensures better, availability of information, and so that the studies follow stricter rules while publishing. So for observational studies, we've got STROBE. For randomized control trials, we've got CONSORT. And for systematic review and analysis, we've got PRISMA. And for case reports, we've got CARE. So today's study, I would actually like to present in terms of their adherence to the PRISMA criteria and how well they have stood out on that front. So this is a PRISMA 2020. PRISMA stands for Preferred Reporting Items for Systematic Review and Meta-Analysis. And it is a checklist of 27 items. And basically it just establishes, a baseline for all meta-analysis and systematic review so that they adhere to this, and it just improves the quality of the research material that is available. So these are the 27 points. So to start off with, the title of the study is Comparison of Surgical Decompression and Steroid Therapy for Management of Traumatic Optic Neuropathy and a Systematic Review and Meta-Analysis. So as we can see, the title itself establishes that it is a systematic review and meta-analysis. So it meets the very first criteria of the PRISMA 2020 checklist. And for abstract purposes, PRISMA also has got its own separate guidelines for the abstract. And in this front, we can see that it had not met all the criteria. there were about 6 criteria which were not met, which includes mentioning the inclusion and exclusion criteria, and also the methods that were used to assess the risk bias in the study, and limitation of the evidence which was available, and giving a general discussion and interpretation of the results. The funding was also not mentioned, and the registration was not mentioned in the abstract. However, these points have been mentioned in the study per se in the full text. Now, going back to the Prisma for the full text study, so introduction part, the study at the outset itself establishes there are certain gray areas when it comes to treatment of traumatic optic neuropathy, which includes the type and indication of intervention and timing of the intervention, and also randomized controlled trials are very few and far in between, and the quality also is like very limited. And it also states a clear objective, which is to understand what treatment approach is better for traumatic optic neuropathy, whether it's surgical decompression or the steroid therapy. So on these two fronts, it meets the items on the checklist. So to just tell about the methods in brief, so this systematic review had actually followed the Prisma P, that is 2015 statement, but what we are checking it against is the Prisma 2020 criteria. It is also mentioned that the study was registered in Prospero, and they've also given the registration number. The literature search strategy which was used, so they had entered the keywords in PubMed, Embase, Ovid, and Scopus databases and found out the articles, and they had put a last search date being as July 31st, 2021. There were no other time restrictions. And for the study eligibility, what they had done was inclusion criteria. They follow the PCOS criteria, which was basically P, which stands for population. So that is all patients with post-traumatic optic neuropathy. I, which stands for intervention. That is all the cases of post-traumatic optic neuropathy which were managed surgically. And comparator, that is C, or the control group, which is basically cases that were managed non-surgically using steroid therapy. And O, which stands for primary outcome, which is nothing but the improvement in the visual outcome. And studies, S. That is the studies that were included were mainly the randomized controlled trials, the prospective cohort studies, and case control studies, and case series which had more than 10 as a number. And only English language papers were included in this review. And as far as the exclusion was concerned, they had excluded all other review articles, meta-analysis, expert opinions, letters, opinion pieces, and also case series with less than 10 cases. And they also avoided those articles which chose conservative management in the form of head elevation and close observation without any therapy. So even that criteria was met. And then they had also specified all the databases that they had gone through to achieve this information, which is nothing but PubMed, Embase, Scopus, and Ovid. Now coming to the next one, so they had specified what strategy they had used. So in case of PubMed, they had used a mesh terms, which stands for medical subject headings. So it helps fine tune the search and give articles which are more relevant to or pertinent to the study itself. And similarly, they had also followed for Embase and Scopus, and they have also given a total number of articles that were found through each of the database. So the data extraction process, as far as that was concerned, the first two chief authors of the paper reviewed all the articles and entered the data in a piloted Excel sheet. And any disagreement which was there was solved by the third author. And the fourth and fifth authors were involved in proofreading. So there's a clear demarcation of the responsibilities of each of the author. So in selection process, that is what the 8th item of the checklist, it mentions that whether the study like how did they decide on which studies met the inclusion criteria of the review, and also how many reviewers had screened and whether they did the thing independently or not, and also if there were any automation tools which are used for the same. Then in the data collection process, basically they're checking how the methods that were used to collect the data and how many reviewers were involved in the same, and if any automation was used for the same. So as far as these points are concerned, even that was met in the study. So the next one is data items. That is the 10th point in the checklist. So that is further divided into 10A and 10B. So here they have mentioned what kind of data was extracted from the studies that were included. So that is here the country of origin, the authors, the number of patients who had undergone the surgical treatment and had shown improvement, and the number of patients who had undergone the steroid therapy and also shown improvement in visual acuity. But at the same time, 10B, which is basically list and define all other variables for which data was sought, that criteria was not met. That includes information such as what kind of head trauma and the severity of the head trauma and what was the regimen of the steroid therapy. These kind of information was not included. And then checklist number 11 includes finding whether any methods were employed to assess the risk of bias in the studies. So here a funnel plot was done to check for the publication bias. And checklist 12 is to specify for each outcome the effect measures, that is the risk ratio, mean difference, etc. So here it is clearly mentioned that the data was extracted and the continuous variables were expressed as mean plus or minus standard deviation, and the dichotomous variables such as whether there was improvement in visual acuity, yes or no kind of questions also were recorded. And this extracted data was subjected to meta-analysis, and a relevance software 5 was used for this analysis. So the checklist 13, in that there are synthesis methods. So that is further divided into 6 points. So the first one being describing the processes which are used to decide whether the study was eligible for synthesis. So this is like preparing a tabulation and mentioning the characteristic of each of the study that was included in the meta-analysis. And 13B is describing any methods which are required to prepare the data for presentation or synthesis, such as handling of missing summary, statistics, and data conversion. 13C is describing the methods used to tabulate or visually display the results of individual studies in synthesis. And 13D was if the meta-analysis was performed and describe the model or the methods used, and also if there was any automation that was used for the same. 13E is describing the methods used to explore possible cause of heterogeneity, and 13F was describing the sensitivity analysis. So this 13F criteria was not met in the study. So here they have mentioned that heterogeneity of the studies was analyzed with Cochrane Q and I-square values. So when the I-square value is more than 50%, it indicates that there is a moderate level of heterogeneity, and therefore the random effects model was used for the same. And if it is less than 50%, then it would mean that the heterogeneity is not so bad, and the studies can be clubbed together to identify the pooled effect size. So here, when the heterogeneity was found to be more than 50%, subgroup analysis was further performed to find out what were the reasons that was contributing to such kind of heterogeneity. So this is a characteristic of the studies included in the systematic review. So here in the first column, we can see that there is an author and the year of publishing. And then they mention the study design, which includes retrospective studies or whether it was non-randomized prospective study or whether it was randomized control trial. As we can see, there is only one randomized control trial among the 16 studies that were selected, and 11 of them were retrospective studies. Then the next column is the number of patients which were treated with who were treated with surgical decompression, and the next column is how many of them showed improvement with surgical decompression. And then we have the next column, which is how many patients were treated with steroid therapy, and the next one is how many of them showed improvement with steroid therapy. This column is basically showing what was the approach used for surgical decompression. So the different approaches that were there was transethmoidal, transconjunctival, and also transcranial. And NM, wherever they have mentioned, that means that the technique was not mentioned in the study. So now here we can see that the visual acuity in different papers were analyzed with different techniques. So in some papers they had used Snellen's chart, whereas in some they had used VEP, especially when the patients were unconscious. That was their way of checking the visual acuity. And then some of them had adhered to logMAR. And in some of them, it was not specified how the visual acuity was checked. And this ST used basically indicates what kind of steroid therapy was given. So DMS stands for dexamethasone, and then some of the articles included prednisolone, and some of them had given IVMP, that is IV methylprednisolone. Now, the last two columns are very important. That is basically critical appraisal of each of the articles that were included in this meta-analysis. So how they had done that is, this MS stands for minor score. So they had scored each of the non-randomized studies based on this scoring system. And that is a score that they have mentioned here. And then the last one is Jadad score, which is specifically for control trials. So for the RCT, they had used Jadad score. So it also adds to the credibility of each of the study that was included in this meta-analysis. Now, coming to reporting the bias assessment, so they had actually made a funnel plot for the same to indicate the publication bias. When it comes to the checklist point 15, they had not used any methods to assess the certainty in the body of evidence for an outcome. So that part is not, that criteria is not met. Now coming to the results of the study. Study selection in that 16A and B points. So that is nothing but describing the results of the research and selection process from the number of records identified. That is basically how the authors went through the entire process of selecting the articles and how they, even if they found articles that were pertinent to their study, they excluded some of them, and why were those articles excluded? And they have given a very good flowchart for the same. And then the next 16B is site studies that may appear to meet the inclusion criteria but were excluded, and what was the reason for excluding it. And study characteristics, as I already mentioned in the previous slide, they had given a very good table explaining how different studies, the characteristics of different studies. So this is a flow chart for the search and selection process. As we can see here in the beginning, the records were identified through PubMed, Embase, Ovid, and Scopus, and they had a total of 7,100 articles. And after removing all the duplicates, they ended up with 4,900 articles. And after screening them, that is basically going through the abstract of these articles, they excluded 4,800 because these were not pertinent to the research question that they had. And then they assessed the remaining 148 articles. That is, a full text was assessed. And what they found was 122 of them were single arm studies, and 7 of them were double arm but with no surgical intervention, and 3 of them had data ambiguity, and hence they were excluded from the study. So they ended up with 16 articles which were pertinent to the research question, and these were further subjected to quantitative analysis. So the results in brief, what I would like to say is that there was a total of 1,046 patients from 16 studies which were included in the meta-analysis, of which 590 patients had undergone surgical decompression and 343 events of visual improvement was there. And 456 patients had undergone steroid therapy, and out of that 252 events of visual improvement was there. Now, the important point to note is that different authors had used different forms to check the visual acuity. So some of them had used Snellen's chart, some had used Logmar, and some had used BEP and Landau's chart. So this is what contributed to the heterogeneity in this study, and that is why a subgroup analysis was mandated. So they divided the studies depending on the criteria that they'd used to gauge the visual improvement. So some studies had used 1-line improvement, some of them had used 2-line improvement in Snellen's chart, some had used 3-line improvement, and some of them had used Logmar. So based on that, they had divided all the studies into 6 subgroups and subjected that to further meta-analysis. And what they found that there was a significant heterogeneity where I-square is 66%, that is more than 50%. And that is the reason that they had to do the subgroup analysis. And what they found was that there was no statistical significant difference between the subgroups, with overall heterogeneity among these subgroups being 37.3%. However, when they use a subgroup with 1-line improvement in Snellen's chart, they found that the whole protocol favors use of steroid therapy. So there they found that the p-value was 0.02. That was statistically significant. So this is the forest plot. So here we can see that this is the first group, which is where they were looking for 1-line improvement in Snellen's chart. So here there were 6 to 8 studies which were included among the total 16. And here we can see the central line is the line of no effect, whereas these horizontal lines are the confidence intervals of each of the study. So the wider the confidence interval line is, the lesser is the precision of the study. And then we can also see the blue dots or squares. Ideally, they would be squares, which actually examines the weight of the study. That is how much it contributes to the final outcome of this subgroup analysis. And this final diamond is the pool effect size. So the central part of it gives a pool effect size, whereas the width of the diamond would actually suggest the pool confidence interval. Now, how we normally interpret the forest plot would be that if this diamond were to cross the line of no effect, it would mean that there is no statistically significant difference. However, here it lies on one side, and we can see at the bottom of the graph that the right side favors steroid therapy, whereas the left side favors the surgical decompression. So here in the first subgroup analysis, so whenever they reduced the Snellenstadt improvement threshold criteria as one line, they found that there was a statistically significant incline towards going for the steroid therapy rather than the surgical decompression. Remaining all studies, we can see that the diamond actually crosses the line of no effect, and therefore they were not having a significant contribution. Now, again, going back to the PRISMA, so point number 18 was present assessments of risk bias for each included study. This part was not met because it did not look for the risk of bias for each study. It just gave a pooled information about the risk of bias. And then point number 19 is for all outcomes present for the study, the summary statistics of each group. As I showed in the forest plot, for each subgroup, they had shown the summary of statistics and also the confidence intervals. And point number 20 is result of synthesis. So in that, we have further divided into four categories, which is 20A, B, C, and D. So 20A stands for summarizing the characteristics and the risk of bias among contributing studies, as we saw in the forest plot already. And then 20B is present the result of all the statistical synthesis conducted, which also was given in the forest plot. And 20C is present results of all investigations of all possible cause of heterogeneity among the study results. And 20D is sensitivity analysis conducted to assess the robustness of the synthesized results. So as we can see, 20D criteria was not met. And about 20C, I will be talking in the next few slides. So as we saw that there was a gross heterogeneity in the study because of the different criteria used by different authors to determine the improvement in the visual acuity. And that is why the subgroup analysis was done. Out of the 16 articles, 6 articles specifically mentioned about patients with no light perception, and that is what is given as NLP. So a second meta-analysis was also done on the studies which included this NLP, and it was done to compare the effect of surgical decompression and steroid therapy in such patients. And in such cases, they had considered any improvement in vision, whether it was just converting into PL positive or counting fingers, even that was taken as a positive event. So what they noticed here was that there was a 46% improvement in patients with no light perception when they were treated surgically, when compared to only 25% who recovered from NLP when treated with steroid therapy. So the meta-analysis of the odds ratio for this no light perception group revealed that I square was 48%, and this is less than 50%, so the heterogeneity was not as much, and this mandated a fixed effect model, suggesting that there was no statistically significant difference between steroid therapy and the surgical decompression. So although we can see that the number is so high, 46% and 25%, still the final outcome of the meta-analysis was that there is no statistically significant difference between surgical decompression and steroid therapy. Now coming to reporting biases, as I said, the funnel plot, I'll be coming to that, and certainty of evidence. They had not presented assessments for certainty or confidence in the body of evidence, and that part of the checklist is not met. And coming to discussion, so they have given a general interpretation of the results in context of other evidence, and also they have discussed the limitation of the evidence. However, they have not discussed the limitations in the review processes that they themselves have used, and also they have not mentioned about the implications of the results for practice, policy, and also for future research. So this is a funnel plot that I was talking about. So this is basically the funnel plot for all the 16 studies that they had put. And ideally, what we expect is an inverted funnel with a symmetric distribution. But here we can notice that there is a concentration here, and it is not a symmetric distribution at all. This is classical of a condition where negative studies with small sample sizes are usually not published, and therefore the publication bias. And this funnel plot is for the 6 studies that included patients with no light perception. And here it is a roughly symmetric distribution, but however, there were no enough study points to confirm the same. So here they have mentioned the same, that funnel plot for studies included in the meta-analysis of patients with NLP represent no significant publication bias, which was within acceptable limits. Now, as far as the discussion is concerned, the findings of this study was in contrast to another study, meta-analysis, which was done by Rafael et al., which concluded that surgical decompression is a better alternative than steroid treatment. And the earlier when administered, the better would be the results. However, the study included lesser number of patients and also failed to address the heterogeneity of the visual acuity assessment methods. And this meta-analysis also included an RCT. The current meta-analysis that we are discussing also included an RCT, which was well designed. And the findings of this meta-analysis also corroborate with that of the RCT conducted by Chen et al., which stated that there's no statistically significant difference between the treatment strategy, that is steroid therapy and surgical decompression. So grossly, the authors have also mentioned the limitations of the study, which includes that there was only one RCT that was included in the whole study, and the fact that the visual acuity assessment was not uniform, and then the steroid therapy and the surgical decompression protocols followed were also not uniform throughout the study. Now, coming back to the PRISMA, so as far as these points are concerned, 24A, the author had registered the protocol in Prospero, and the registration number was also given. And the review protocol, whether it can be assessed or not, this information was not mentioned in the study. And whether any amendments were made to the information provided at registration was also not mentioned. The funding and the competing interest, conflicting interest, all have been mentioned in the study. And finally, whether the data can be accessed publicly, that is, the template for data collection forms and data extracted, and also the Excel sheets, the master charts, all this information was not furnished in the study. So now moving to the discussion. So steroid has a neuroprotective role. It has been known conventionally.
Can you please,
it's almost...
just finish fast.
So the steroids actually reduces prostaglandins, and it also prevents free radical injury, and therefore the neuroprotective role. But in the recent times, this has been come to question, especially because the CRASH trial, which was conducted in 2004, and said that it is basically corticosteroid randomization after significant head injury. And as per that trial, they had noticed that there was increased mortality with high dose steroid with substantial head injury. So what is the normal steroid protocol that is followed is high dose is usually given with a loading dose of 30 milligram per kg, followed by continuous infusion of 5.4 milligram per kg per hour for 24 to 48 hours. And 4 studies out of the 16 studies had followed this high dose protocol. And 8 out of the 16 authors had used intravenous methylprednisolone. The dosage duration also varied in different studies from 3 days to 3 weeks. And the most commonly used protocol was 72 hours of observation after starting steroid to look for improvement in vision. When it came to surgical decompression, as I stated, there were 3 approaches used by them, that is transcranial, transethmoidal, and transconjunctival. Now, lesser invasive endoscopic transethmoidal approach is available, and hence transcranial is not preferred in the recent times. So the indication for surgical decompression, as per one of the articles included in this meta-analysis, was 72 hours of steroid therapy with no improvement, progressive vision loss, and also total blindness with optic nerve compression on CT. So in light of the CRASH trial, surgery seems to be a better option, especially in patients with polytrauma who has to anyway undergo other surgeries under GA. So this is a patient selection criteria. Here, I just want to highlight one study, which is Mahapatra et al., which stated that they gave 3 weeks of steroid therapy and then assessed whether the patient required surgical decompression or not. So what I want to also mention here is that the surgery, like the timing of the surgery itself was different in different studies, and that itself can confirm the results of the study. So in conclusion, the meta-analysis concluded that there was no significant difference in steroid therapy and surgical decompression in terms of improvement in visual acuity. And even in patients with pre-treatment vision of no light perception, there was no difference in their response to surgical decompression or steroid therapy. So the limitations of this study was mainly the different criteria which was used in different articles for gauging improvement in vision. So that contributed to heterogeneity, but they tried to make up for it by going with the subgroup analysis. And then surgical decompression protocols and steroid therapy were non-uniform in the study, and hence it still does not shed light on what protocols to follow for the same. And nature of the head injuries and their severities were also not mentioned in the articles. And one study, as I already said, Mahapatra et al., had an observation period of 3 weeks before surgically intervening. And this time lag itself may serve as a confounder and a negative case in point for surgical decompression. Sensitivity analysis to reconfirm the findings was not done, and only one RCT was included. Thank you.
Excellent presentation, Dr. Nisha.
Thank you.
Yeah, I request the mentors and the panelists to start the discussion, please.
Ma'am, basically we just chose this paper to highlight how to go about reading meta-analysis, basically, because pages are mostly presenting other journals. So the main intention was to highlight the PRISMA criteria, and I think she has done a good job on that. And basically the results, again, we are at crossroads between the steroid and decompression. So centers where, like particularly in Bangalore, when we are in NIMHANS, there are opportunities for decompression. So wherever there is a facility for decompression, navigation surgeries, those can be utilized. But in most other centers where these are not available, steroids still forms the mainstay of treatment. Over to the discussants.
Nisha, you have presented very nicely. I have a couple of questions.
Yes.
Has this meta-analysis mentioned about the pulse steroids were given in all cases, or the oral steroids? I mean, it's just given steroid therapy.
Yes, ma'am.
So, oral steroid were also included in the study. The studies which they chose,
yes,
had they given oral steroids also?
Ma'am, actually, that part was not mentioned.
So that's one of the drawback, because it's not mentioned, because it's a pulse steroid or whether it's a oral steroid again.
Yes.
And another thing which has to be mentioned, like the onset of trauma to the intervention. That thing is important.
Yes,
so when we compare the studies, both these informations are important.
Yes.
If we have to compare one-to-one, whether which one is better. Of
Yes,
course, surgical decompression is better in cases of semi-comatose patients or with severe head injuries, and you have the facility of surgical decompression at the same time when you are operating on other injuries as well.
Yes, ma'am.
Of course. And yes, and as far as steroid is concerned, whenever the patient come back to ophthalmologist after the injury, and whenever the patient has gained consciousness, and if the patient has not received any decompression or any other therapy, then of course an ophthalmologist should go for a trial of steroid therapy, because in our center also, no matter the patient comes late also, we give even after 7 days, even after a month also sometimes. So we give a trial of IVMP, and in few of the patients we have seen some improvement, because in one of the study there was a mention that even in the delayed cases of traumatic cases, wherever there is a edema, there is a delayed compression, delayed axonal degradation, which basically there is a papillomacular bundle loss. So if you give an IVMP, even if it's late, even if the vision do not recover, but it's a symptomatic improvement, which we have seen in many patients. Maybe there is no significant difference in line, if you see.
Yes.
It's like 2/60 improving to 3/60, or 1/60 improving to 2/60, even if that patient is happy. So I feel the steroid is a very in young patients especially, it's a very good modality. And I think even if the results do not favor it, because they say that it's equal. In one of the study, even if you go in the Cochrane database, if you go and search for the steroid therapy, they say that it doesn't have any role after 7 days. But in our center, when we have given it, we have found symptomatic improvement, as well as we have found, so in some of the patients, we have found a significant improvement as well. It's good if you can give it on time within 48 hours, but even if they're late, it should be given.
Yeah. Any other inputs by the other mentors? You can stop.
Pulse steroid always work, not the oral steroid. And I think the studies which has given oral steroid should not be compared with the surgical decompression. I think the other discussants have left. So I think we had a good presentation and a good discussion.
Yeah, thank you so much, Dr. Shilpa, Dr. Chinmay. Thank you, Dr. Akanksha and Dr. Nisha for presenting so well. So on behalf of ARC and AIS, I would like to thank all the mentors, the speakers and the panelists for being here, sharing their valuable time, and giving us such a lovely presentation and good insight on the journal. Thank you so much.
Thank you.
Thank you.